Welcome to episode 7 of Brain Injury Professional Casual Conversations. I'm really excited to have you here and that you've chosen, so many of you, to spend an hour with us talking about brain injury in a casual format. The idea came from the fact that we don't have conferences and we aren't having those casual conversations. So the talk today is like if we sat down all at a conference at a large table, didn't know each other, but we're all interested in somehow connected to brain injury. So today we have a very exciting guest who I met last February at the NABUS event in New Orleans. And I remember waiting for tea. I think he was waiting for coffee, and it's one of those awkward moments where you both stand at the table and you're waiting for something and you say hi to each other. So what started as a conversation has now ended up a year later. We have a paper written together. Consider him a friend. He did all the math on my paper in a weekend. Just great guy. So I'd like to introduce you to Dr. Haider. Welcome.
Hi, thank you for having me. It's a pleasure to be here.
I was thinking, with the lack of conferences, it's just so hard. Tell me about that conference for you. I know you found it a pretty valuable conference to attend.
Oh yeah, the conference, it was in New Orleans. It was like right before COVID hit, so it was a kind of exciting time. But I met so many people. I go to conferences to network, to try and find people who have data and who want to share their data with me to analyze and write about. So yeah, you were one of them. It was very nice.
Which was kind of funny because originally I came up to it, I was trying to describe it and I got tongue-tied. So I ran off and found my data, and then like a little puppy followed you out and like, here's my data. And it was a really big deal. We actually shared a stage at one point presenting our data. And then I think you called me and said, let's talk about your data. So that, which is now turned into a paper between the two of us and some other great people that I've met along the way. So I would love to just share a little bit about yourself, where you're born and where you grew up and how you got to brain injury.
Sure. I'm from Pakistan. I grew up there. I have my MD from over there, and then I moved to the US and I got my PhD from over here, from Buffalo. And I've always been in academia, teaching, and these things. And over a period of time, just from trying to understand the brain psychology, I went into more traumatic causes of impairments after traumatic causes of impairments, and then slowly it just went on to mild traumatic brain injuries and now concussions.
And how did you end up with Barry and John? How did you end up at the lab?
Oh, okay. Well, this is a pretty interesting thing. So I've actually only worked in one place my entire life. I was Barry Willer, he's my mentor. He's the one of a pioneer in active recovery from concussions and traumatic brain injury. So I was a volunteer under him a very long time ago, 8 years ago or something. Then I became his graduate assistant. I was his postdoc. I also did my PhD under him. And now I'm his assistant director of research at his lab. So yeah, I've only been here.
You guys have a long history together. That's great. And both Barry and John have spoken at Pink Concussions events. I tweeted out a video that John put out today. That was from 2017 that I put out today. And so, the lab and both those men and you have been so supportive of our work. And one of the most exciting things I find about what you guys do is you're actually talking about rehab techniques. And I wondered if you could tell us a little bit about the lab and what the emphasis is and what you're studying.
Okay, sure. All right. So I'm more of a researcher than a clinician, and my research is actually focused on understanding the autonomic nervous system and methods of quantification. So first, like first we try to understand, like what is a concussion and what is, like what were one of the main pathognomonic findings of a concussion, which is, like exercise-induced headaches, just the variety of non-specific impairments that actually happen after a concussion. So using that exercise, that causes headaches, we tried to see if we could diagnose people with a concussion using exercise tolerance. So Dr. Willard and Dr. Letty, they developed the Buffalo Concussion Treadmill Test several years ago. This was like way before I joined the lab. And then using that, then I actually did a lot more work on the treadmill test, trying to identify if, this heart rate with, symptoms happened, was it replicable? Was it prognostic? What other things we could actually do with it? And we actually found that if people exercised at a heart rate below that threshold, that symptom threshold, and the exercise, they kind of like challenged their autonomic nervous system slightly, like a bit, not too much to cause, to cause too much of an issue. But if they exercised right below that threshold, their symptoms would improve faster. There would be a slightly lesser chance of, going into delayed recovery. And generally people were a lot happier with being able to, do any kinds of physical activity. Because if you guys recall, just more than like 10 years ago, not more than, this is also pretty recently, a lot of people still prescribe complete rest after a concussion. And there has been a lot of research and data showing that, complete rest is detrimental, it prolongs symptoms, or, you just never know when someone is recovered.
My son I came into the concussion world when my son was concussed in 2008, and he actually was under care of one of the doctors that wrote the paper on what they were calling the cocoon theory at the time. And he writes, Dr. Lee, that it was supposed to be several days, but it got extrapolated to several weeks, several months of absolute complete rest. And that really was, at the time, what people were saying. You go home, go into a dark room, and then from nowhere came Buffalo Protocol.
Yeah, so it actually didn't come from nowhere. Dr. Willer has been working on this for the past 35 years. So it's actually really, he started off with, let's see, how did he, okay, so Dr. Willer is also a hockey coach. And a lot of his players had concussions, and he kept on seeing that, they're just being prescribed to rest, and their symptoms are just getting worse. Like when you take a teenager, they're active, they're playing sports, suddenly they have a head injury, and then you tell them, oh, you can't play your sport that you want to play. You shouldn't hang out with your friends, limit your activities, social, and, anything that, is fun. And then, these patients, they used to complain of headaches, like irritability, like feeling slow, just so many non-specific symptoms. And, you could never tell if this was due to a concussion or because of the treatment. If they were is it because of they're just like sitting at home, not exercising. So he originally, tried to figure out like a more active method of recovery. And then he met Dr. Letty like more than 20 years ago. And then they started developing the Buffalo Concussion Treadmill Test, which is actually it's so funny that this treadmill test has become so famous, because it's actually used like internationally for concussion diagnosis and prognosis and recovery. Because, people have asked me from the Middle East, Australia, many European countries, like how to do this. They've given me their experience with it. And we've kept on, updating our treadmill test protocol. And one very funny thing was actually happened like just last week. So, there was the AFC finals. Patrick Mahomes had had a concussion, and everyone was asking, "Oh, is he going to be playing the in the finals, in the AFC finals?" And I was just like, "Oh, I have absolutely no idea. I'll go." But I read a blog. It was, sorry, not a blog. It was just like a random article. It was like, "Oh, Patrick Mahomes has to beat Buffalo twice. First in the Buffalo concussion treadmill test to be able to play, and then, well, at the against the Bills, and well, he definitely defeated both pretty easily." So
That's
yeah.
awesome. That's really funny. And it really was, I mean, I actually didn't realize the history that went into it, but suddenly that was, Buffalo Protocol was everywhere. And I remember I've been with Dr. Letty where people have said, how will I know how to do this? And he's like, you get a heart monitor and you stay below your sub threshold aerobic. Like he's very like giving of the information, and there really isn't like a huge thing. There's nothing that you're selling around it, and I think it can be universally applied with a doctor's overseeing it.
Oh yeah. I mean, we generally, the best treatments are those treatments that patients want to do, that they're going to be compliant with. And plus something that is easily, understandable. So we try our best to make it accessible.
And I do want to say, if you're someone with a concussion and you're watching this, we have links to papers that you can read, that you can take to a doctor, and everybody's concussion is different, everyone's own body and what they can tolerate. So we're going to continue talking about this, but don't take on an exercise plan without checking with your doctor first, because we're not giving you medical information. We're just giving you information about the research, and you'll need to take it to your doctor and figure out. So with that, can you tell us a little more about what differences that we would be interested in talking about sex and gender? How do women differ from men just in the test in general?
Okay, so the thing is, most of my research is actually focused on understanding the autonomic nervous system, specifically methods of blood flow regulation. We recently just finished a paper in which, there are no specific differences in the method of in the results that you get from a treadmill test between sexes. It's diagnostic of exercise intolerance. It's not associated with delayed recovery or any negative outcomes that last for longer than a day. And even the heart rates at which males and females get symptomatic is pretty similar. So, prescribing exercise, subsymptomatic exercise, is just, like 90% of their heart rate. So this test is pretty useful for both males and females. However, when I assess, when I'm researching like blood flow or cerebral blood flow, either using a transcranial Doppler or ASL or, any other methods, there are a lot of differences between males and females. And that is, well, that's just due to so many different things. Because, okay, so like on average, like the female skull is smaller than a male skull, but the brain still has to, do all the same functions that, the bigger brains, like the male brains have to do. But because of that, they're more denser. The neurons are smaller, but there are more of them. Their microtubules are slightly more narrower, but they're a lot more. And so the thing is, just because there are so many differences at baseline, like just in the structure of the brain, its blood flow and its blood flow regulation is also different. Like females on average, like healthy females, like not in the context of concussion, they have slightly higher blood flows and blood flow velocity and than males, and on their responsiveness to like certain physiological testing that I do, like like rebreathing carbon dioxide, assessing vasoreactivity, or these other things. It seems like they're just a bit more, the magnitudes are just slightly different just because their baselines are different, but it's still how should I say this? It is really complicated. But it's different.
Yeah,
There are differences, and there are a lot of differences. But just understanding these differences is how we understand this concussion, and we can actually improve treatments or better direct treatments based on it.
And so, what did you find with concussed females when you had applied sub-threshold aerobic exercise post-concussion?
Oh, okay. Sorry. That's like more like clinical stuff. So yeah, we've done a couple of clinical trials in which we've taken patients with a concussion. Oh, sorry. We mainly treat. Most of my studies are always on the adolescent population, just because adolescents, they take slightly longer to recover, and it's just because they're in school, their parents take them to the doctor like a bit more faster, or like there's just
Good to have parents.
it's good to have parents, and plus there are just a lot of adolescents with a lot of sports related concussions. So yeah, that's why most of my research is on the adolescent population. So when we so we we've we so patients with acute concussions, like within 10 days of injury, we've put them on a treadmill test, and then randomly assign them either to do like either 80% of the treadmill test, 90% of the treadmill test. Sorry, those are two separate studies. Or we've given them like a placebo like exercise program, which is supposed to mimic relative rest. And we've actually found that that both males and females respond equally well to treatment, okay, if they are treated. Now, a lot of previous research that always showed that that females would take longer to recover, or they would have more, they would have a higher incidence of persistent symptoms, or like a lot of those papers, they didn't really specify what treatment they were giving, because apart from the type of treatment you're giving, it's when you were getting the treatment, or like how, like there are a lot of social factors that come around into like getting in rehabilitation.
We had Dr. Masters on here who was talking about her study that that women were taken to, but girls by their parents were taken later than boys to doctors. I've also seen that in my own research. So yeah, when did the patient get to care, and what kind of care was given?
Oh, okay. So the thing is, in these studies, both males and females, that we give them they are assessed and prescribed exercise, like a structured aerobic exercise plan. So like they exercise at this heart rate, ±5, for 20 minutes a day. They can either go for a jog. It's actually best to use like a stationary bike, because then there's no like chances of them like falling, which is obviously, a hassle if you
have fallen off a treadmill. So I would be I'm a stationary bike girl.
Yes, especially if you have if you have a concussion, then your balance is slightly off, or your vestibular system is kind of off. So there are more chances of like people with the So that's why I just recommend like exercising on a stationary bike. And I'm so sorry, I've lost my train of thought. Can you?
So in that study where you had men and women, and they both are adolescents, both of them responded equally positively to exercise. But then in the group that was prescribed the stretching placebo, what did you find in that group?
Oh yeah. So the thing is, okay. So we found that, okay, so like we've done a couple of trials in which, like first we just did our standard of care without controlling for any, without doing like a proper randomized control trial. In those studies, like our female patients would actually take longer to recover, and their symptoms would actually like get a bit higher, like even after recovery. It was just like, how should I say this? It was a lot more variable than our adolescent males. But that was only in the groups in which we did not prescribe any like structured exercise or any, you know, like directed treatments. And, you know, like their symptoms got a bit higher like the day after, and they would also take longer to recover. However, you know, in those trials in which we treated males and females equally, in which we either gave them a structured placebo stretching program, which isn't like an aerobic exercise, isn't an active recovery approach. And then we also gave them, you know, the active recovery approach. In both of these things, if they were treated equally, they didn't have the variability in their symptoms, you know, like after their doctor's visit. And I think that just because you know, just because they were getting like the same focus, like attention from their physicians or, you know, like their other medical practice, other, you know, like care providers, that kind of addressed some of the variability in their symptoms after.
I do think that care of you know, access to medical care is definitely a factor, where you have athletic trainers that are on the fields and accessible to everyone, but they're actually at the male sports. They're at more of the contact football type sports than the other sports. And then maybe that's some reason that girls come in later. And then what did you find with the cerebral blood flow of the girls versus the boys after concussion?
All right, so basically, so one of these questions by Lori, I think, it's, you know, how can we diagnose someone's like blood flow on the treadmill test? So there are actually a few things that, few ways that I've done this. You can either put like a transcranial Doppler and assess the middle cerebral artery, and then you can start, then as they start to exercise, you're technically increasing their mean arterial pressure. And your mean arterial pressure and your intracranial pressure, the difference between these two is your cerebral perfusion pressure. So normally your intracranial pressure should always be independent of your systemic blood pressure, your mean arterial pressure. So when we're increasing blood pressure, I try to see like changes in blood flow velocity as a whole, changes in blood flow velocity using morphological waveform analysis, in which you know, you identify, you know, like individual peaks in velocity waveform, and then you can make like an estimation of downstream compliance. We can see that after a concussion, the brain is actually more compliant to blood flow. So if you increase mean arterial pressure, a lot more blood starts going to the brain, theoretically. Like I've only been able to estimate this on velocity waveforms. There's just, well, because a concussion is a mild traumatic brain injury, no one's ever going to let me assess blood flow like invasively, just because of how, well, ethics.
Because it's invasive.
Yes, it is. It's invasive. It's very dangerous, associated with like a lot of complications. I'm talking about like intraventricular catheterization. Yeah, obviously, right. That's very, very dangerous. So yeah, we're seeing that the brain is actually more compliant. So then the brain's normal response is that if there's like an increase in like blood flow to the brain, it kind of decreases its blood vessels, it kind of redistributes its blood from the internal carotid to the external carotid, tries to keep the brain safe. But when the autonomic nervous system is kind of just like, a lot of research has shown that the autonomic nervous system after concussion is affected. And it's not like non-functional, it just has like a slightly more blunted response than normal. So if there is more blood flow going to the brain and the brain just isn't able to regulate it as fast as it normally should, because the autonomic nervous system works a lot faster than, you know, like what we can like consciously do. Like it's stabilizing, you know, like where your eyes are, it's stabilizing where your body is, you know, your balance system, it's maintaining your heart rate, it's maintaining your cerebral perfusion pressure, your bowels, everything. Just because there's a slight reduction or like a blunted response, it just starts, I mean, people start experiencing symptoms of like impairments and these things. So so when someone starts to exercise, and if they have like a blunted ANS system or whatever other you know, like cause, I mean, sorry, so if they start to exercise, they start having more like symptoms. So basically with the purpose of our symptomatic exercise is basically we want to exercise people to right below that level. So we're challenging the autonomic nervous system, but not like pushing past more than what it can, you know, like tolerate. So because if you do more exercise than you're supposed to, you're actually stressing out the brain a lot. A lot of previous research has shown that this is associated with prolonged recovery, and that is one of the main reasons why it was always, that's why, you know, like everyone always, the previous treatment of care was complete rest. Just don't exercise too much, because that is associated with delayed recovery. But if we're just challenging the autonomic nervous system just slightly below the level that it can do, the tolerance level actually increases like a lot faster. And we've assessed this by, you know, like making people come back every week doing the treadmill with and without exercise in between. And we're seeing, you know, like this tolerance actually increases better with aerobic exercise. And currently my focus of treatment, my next idea is, you know, like how do I, you know, like at what percent should people exercise? You know, like should be 80% of their heart rate threshold, should be 90%, you know, like we're still figuring that stuff out. So one of these other questions, which was, you know, like how did you decide on 20 minutes of exercise? It's just 20 minutes sounds like a convenient thing to do for most people. That's pretty much it, 20 minutes.
And then, and she's, what were the parameters based upon? Was there another part of that question?
Oh, sorry, and the plus minus 5 beats per minute? Oh, yeah. For example, like if I'm asking someone to exercise at 120 heart rate, beats per minute, it's impossible to keep your heart rate at 120. So that's why I always say plus minus 5.
In a relative range, right?
Yeah.
So then before we go to a Q&A, so just so that I understand that exercise has shown a benefit for female and male adolescents equally, and that rest could possibly have more detrimental effects on females than males?
Yes, that is what the current research suggests. And so that is exactly why I would say that, well, regardless of what gender or sex you are, concussions should be treated appropriately, and earlier treatment is correlated with fewer negative outcomes.
And then I wanted to talk about, I've seen on a lot of the patient Facebook groups talking about POTS and what the connection is with brain injury and development of POTS, and if you had any comments on that.
Oh, yes. Yes, I actually do have a lot of comments on that. Okay, so I just, what do you call it? Like just 2 weeks ago, like a paper of mine like came out in Brain Injury on the incidence of orthostatic intolerance and orthostatic hypotension after concussion. And there was this was like a sample size of like 300 patients, concussed patients, 200 controls. This was from Buffalo, Philadelphia, New Mexico. I mean, this was like a pretty large study. And so first I need to define a few things. Orthostatic intolerance is just when you're changing posture, if you're having like worsening of symptoms, you know, like maybe you're feeling dizzy, you're getting a headache, or you feel like you're passing out, even without any, you know, like blood pressure or heart rate changes, like
When you
being measured.
stand up after sitting down for a while, changing posture like that.
Oh yeah, so basically standing up from a sitting position, if you just feel dizzy, that's called orthostatic intolerance. Whereas orthostatic hypotension is when you have that feeling and you have like a recorded 20 millimeter mercury drop in your systolic blood pressure or a 10 millimeter mercury or more drop in your diastolic blood pressure. Whereas POTS is if there is like, I think like a 30 or 40 heart rate bump in your heart rate from a supine to a standing position. And basically all of them are come under the banner of an orthostatic intolerance syndromes. And so yeah, almost like a quarter to 30% of patients with an acute concussion do actually present with symptoms of orthostatic intolerance. You know, they complain of dizziness, which they didn't have before. Sorry, dizziness on your like on standing up.
My son would get a sense of a black curtain coming in and he'd get tunnel vision and he would just go like that. And he was always told, you're dehydrated, drink more water. So the poor kid carried water bottle around for a year to drink water to try to get this because he hated that feeling.
Yeah, so the thing is, I mean, that is actually, so dehydration is actually like, could lead to it just because, you know, if your blood volume is lower, your blood pressure is detected by your baroreceptors and your aorta, in your carotid bodies, everywhere. So, and this is actually, and your blood pressure is actually regulated 8 times a second on average. So when there's like a sudden like change in posture, your blood, which is like when you stand up, your blood kind of like goes to your legs or stays where it is, and then, you know, you get up. So there is a slight reduction in perfusion pressure in the top part of your body, which is usually your head. So that's usually why people have the feeling of, you know, like that they're about to like pass out after, you know, like getting up. And that's what, you know, people call orthostatic intolerance, orthostatic hypotension, POTS, etc. But so even though they feel symptomatic and all these things, most people do not meet the criteria for orthostatic hypotension or POTS. So I really don't think we should say that concussion causes POTS just because POTS is, what do you call it? It's a dysautonomia. It's a disorder of dysautonomia. It has like a diagnostic criteria. Like you need to have like a specific heart rate increase during a certain test, like during a specific postural change. So that's why, you know, like, and also POTS has a very strong family history. I mean, it's also more predominant in females. So whenever you have patients, so non-concussed patients, females, if they complain of, you know, like orthostatic intolerance syndromes, usually if you ask them that, does it run in the family, it's very common to hear that a mother and aunt also had these things. So that is typical POTS. And so I don't think concussions can cause like that specific disorder of POTS, but it can cause orthostatic intolerance without that heart rate change. I mean, without that specific number on heart rate change.
That's really interesting, and I think it's helpful. And I think also that there's so much information out there. I think people with concussions that aren't getting better are grasping for what has similar symptoms and going there. I wanted to read a couple of the questions out here. Is there research on how your research was done within a week of concussion? Have you thought of, or is there any research out there on people that have been concussed a number of, you know, post-concussive symptoms over a couple of years, a later case of exercise helping?
Okay, so only our current research is on acute concussions. Our previous research was on persistent symptoms, people who had symptoms for months, just because of it was, it's much easier to get approval to give exercise to people who are stable with their symptoms, with their concussion symptoms, as opposed to someone who's acutely concussed. So, so exercise is good, regardless. But exercise, like specifically the subsymptomatic exercise, it's mainly, or at least I hypothesize it happened to improve the autonomic nervous system acutely after their injury. So that's why it can improve, ocular motor, vestibular, and even, like some cognitive problems in the acute period after injury, when majority of these symptoms are suspected to be due to just reduction in cognitive processing speed. However, after the acute period of concussion is over, when it's been like a few weeks, months after their injury, a majority of the symptoms are actually due to like isolated, they're due to like specific issues in the brain. Either it's due to an isolated cervical issue, neck issue that's causing like a balance or issue, or if it's like an isolated peripheral vestibular dysfunction, or just having so many, like being so acutely after their injury. Exercise is very beneficial. Exercise is also beneficial much after their injury, but I suspect that it is going to be more beneficial just acutely after. Sorry, by acute, I mean within the first few weeks after, as opposed to much delayed. But exercise is good for everyone.
That's great. Thank you so much. And I'm going to open it up now. There's so many of you, and I know you're all doing really fascinating things. So if you could start with just saying your name and then going right to your questions so we could get enough people. And I just want to do a shout out to David Johnson, who wrote me the sweetest letter. Okay, and hey, thank you so much. I'm going to get you back on email. And thank you for everybody to join us. And so why don't you raise your hand if you have a question?
Actually, there are a few questions in the chat, which I want to get through.
Okay, all right, we'll go for the chat.
Sorry, I'm going to just go through some of these questions. One of the questions was, what is SPOTS? Postural orthostatic tachycardia syndrome. What about anaerobic exercise for concussion? Anaerobic exercise is usually associated with a very large fluctuation in your heart rate, as opposed to, like aerobic exercise at a continuous pace. So that's why we always recommend exercising at, doing, like either walking, cycling, like those kinds of aerobic exercises in which there's no drastic fluctuations in heart rate. Like 4.5 years. What are the other kinds? Okay, so that is something else. Are there any other specific questions from the chat that you could think of, Catherine?
Question from the floor, and then I'll start reading. You guys are a lot of great questions here. But is anybody on the floor want to ask a question for a conversation?
I have a quick one. So hi. I'm Dr. Svingos. I'm a fellow at Kennedy Krieger Institute and Hopkins. Thank you so much. This was such an awesome conversation so far and really interesting. I was wondering if you all have looked at all at preconditioning, so like pre-injury level of exercise involvement and how that might relate to some of these thresholds. And I can think, I've always thought about withdrawal being such an issue in athletes, particularly that are getting this healthy dose. I've always wanted to do an animal study, preconditioning rats and then looking at it in humans, but you guys have probably already done that. So I was curious.
Okay, so there is animal research about preconditioning, and it's associated with better recovery outcomes from concussions or pretty much any other things. But the people from the University of Toronto, they have actually done a lot more research on this so they've used this active recovery approach in athletes and non-athletes, and with non-athletes who are not, what do you call it? Their conditioning level probably starts off much lower than, like the athletic population. They generally take like a week longer to respond to this active recovery, because with our athletes, they start, like reporting, like reduction in their symptoms like a couple of days after, like initiation of aerobic, of, like being able to exercise again. But the non-athletic controls, I don't think they've published this research yet, but it took them, I mean, like a week longer to start reporting a reduction in their symptoms, but it was still more effective than rest or not giving exercise.
Interesting. Yeah, I think the animal studies that I have seen showed this kind of protective effect of pre-exercise, but I always hypothesized it would be an opposite direction. If you're kind of, I guess if you're resting afterwards, that's where it could be really dangerous. So really, really helpful. Thanks. I'll look into what the Toronto group is doing.
Sure. Next question from the floor.
Hi, I'm Hillary Loftus. I'm with the Howe Foundation of South Florida, and this is very interesting. I'm getting so much good information from this, and it's great that they're advocating, that to know someone that is involved with this exercise after concussion instead of rest. And I'm wondering, do you think that the increased amount of oxygen in the body from exercise has anything to do with speeding up the recovery?
That's actually a very interesting question. And this actually guided a lot of early research after a concussion. So are you familiar with the BOLD MRI, the blood oxygen level dependent MRI? They found that there was, or the research back in like 2005 to 2010 about, using hyperbaric oxygen to treat concussion.
Yes, exactly. Yes, I'm working with that. Yes. Mm-hmm.
Oh, good. This was like a really big thing early on, and but the thing is, after a concussion, it just seems that, well, does the increase of oxygen coming into the body, if we increase oxygen flow, that would improve the ability to exercise. But I honestly cannot think of how it would cause any direct benefits with either reducing neuroinflammation.
Yeah, reducing neuroinflammation, getting rid of the toxins in the cells, which would be neuroinflammation.
Yeah. Honestly, I haven't thought about changing the oxygen levels at which, I know there are many ways for me to do this. I can use resistance masks to test this. I should probably write this down.
That'd be interesting. Yeah, it'd be interesting to see if the combination of the two, increased exercise, maybe an increased oxygen, would make it go even faster.
All right. That's I always like getting questions. That's how I formulate research ideas.
Thank you. I'd love to, if you do a study, I'd love to see it. I'll look for your email address, or I can put my email address in the chat.
Okay.
Dr. Haider, did we discuss it? Because I know we talked before the call, and then we talked before, and this is the third time I've talked. Did we talk about on this call about why we get the massive headaches when we over-exercise after concussion? That where those headaches come from?
Oh, yeah. So that's actually, okay. So that's actually the main thing which I'm trying to do is, okay. So after a concussion, people complain of exercise intolerance, or they complain of, like worsening of their headaches, mainly their headaches, but also dizziness, ocular issues, some balance issues, on physical or cognitive exertion. Now, I am trying to understand, like my entire thesis was on methods of blood flow regulation and the correlation between blood flow velocity and blood flow in vessels. And so I originally, I mean, because here's the thing, if you start to exercise, you're increasing your blood pressure. More blood is going to the brain, and if the brain isn't able to redirect it as efficiently as it normally should, then that could mean that there is more blood going to the brain. But just more blood going to the brain shouldn't really cause any symptoms. Is it increasing pressure? Because a lot of symptoms, of exercise intolerance, or, like a lot of the concussion-like symptoms that actually get worse on exercise intolerance, they overlap with the symptoms of increased intracranial pressure, specifically benign intracranial hypertension. It's I'm trying to understand why specific symptoms happen. Like you get vision issues, or like blurriness in your vision because of certain ion related disturbances in the axons, in which your audio and visual processing is getting kind of thing. So that's why usually people complain of light or audio sensitivity. So just I'm still trying to understand that. I think we have a question by Jennifer.
Makes me happy.
Hello, doctor. Thank you, Jennifer Buchanan. I was wondering what you had, or what information you might have on the commonality of the adolescents being concussed and neurological, just related to what you were just saying, ophthalmological neurology issues after being concussed. I myself, I've had a few concussions, the worst being 5 years ago. And I now have to have prisms and filters in my glasses. I get them through the VA, and that's because of it's a direct result of the concussions. And I wonder what you find in adolescents related to this and pertaining to what you just commented. Thank you so much.
Oh, you're welcome. And thank you for asking a good question. So with adolescents, so I researched sport-related concussions. These are a lot more milder than, like concussions that you can get from abuse, from car accidents, from, like more severe injuries. Generally, I feel that adolescents, I mean, yeah, they might be research shows that their symptoms might persist for a bit longer than adults, but they bounce back pretty fast. But unfortunately, when someone is in school, or like going through their adolescent years, their secondary sexual development, their permanent personality is like setting in, if there's suddenly like a hiatus in their development, for example, if they get a concussion, they had to take a break from school, they had to do so many so anything that causes like a disruption in people's developments will have permanent effects. So this is definitely, I mean, a lot of people are working on the permanent effects of concussions, and how many concussions is too many, or, like, why do all concussions not present the same? Because concussions are, I mean, most of you are familiar with concussions, and that it's a very heterogeneous group of disorders. I mean, people can classify concussions into physiological, vestibulocular motor, migraine, like cervicogenic, like there are a lot of clinical subclassifications after a concussion, just because even like right now, I mean, we might have studied the brain like in a lot of detail, and we kind of understand like a lot of things that happen after a concussion. We just I mean, even though we know why that they happen, we just don't really know. We just don't understand why they happen. So this is still something that we're going to keep on studying for the next several years. I hope that answered your question.
And I think that's why concussion brain injury is so exciting. And it always has been kind of the ugly stepchild of neurology. And like, we just weren't invited to the big table to play. So, you know, I think that I know I was at the CTE conference at NIH, you know, and we were talking about CTE and how to grade it. And there was some Alzheimer people there patting us on the heads going, oh, it's okay. We remember when we were at, you know, your stage. I mean, the other neurology, I think neurology, other areas are ahead of brain injury. It doesn't mean, but so it's an emerging time. So I think it's really exciting, and work from your lab and your work will, I know, you know, is profoundly changed personally my life, my advice to other people. I think if there's one lab that has really changed what we're doing, it's you guys at Buffalo. I see Connor, you have your hand raised. Hey, Connor.
Yeah.
Hey, Connor.
Hi, Catherine. Hi, Nadir. Thank you so much to both of you for running and for being a part of this. I really appreciate it. With Concussion Alliance. And I had a quick question about, I know you said that exercise, or have you found that exercise has helped reduce ANS dysfunction or dysregulation in acute concussion? And for persistent symptoms, you talked about, you know, individualized issues like chronic cervical or vestibular dysfunction. Do you think that exercise for a patient with persistent symptoms could still help improve ANS blunting, even with or despite these other individualized issues?
Oh, yes. Now, if someone's going to ask me if exercise would make people feel better, I would always say yes. But how exactly does exercise affect, you know, like chronic issues? So, I mean, a lot of research has shown that, you know, like exercise actually increases like this one chemical in the brain called BDNF, brain-derived neurotrophin factor, that improves neuroplasticity. I mean, that's associated with like a lot of beneficial outcomes after a concussion. So, you know, like so if there are chronic issues, and so, I mean, there could be a possibility that it could be fixed, but you definitely need directed treatments. Like if there is an isolated oculomotor issue, then that needs to be treated. I mean, that can't be treated with exercise.
Yeah, I did want to put out there that there are things that there are parts of on all the sub levels of concussion that exercise does help. It's not going to help with, you know, a visual issue. So again, you have to be specific about your particular makeup of a concussion, what of the subgroups you have, and then Mickey Collins has this 6 trajectories of concussion. I love that paper. But what of those trajectories you have, and how exercise can fit into some but not all. Okay, we have about maybe time for one more question out there, and there's some really good questions on the chat. Any questions from the floor? I'm reading. There's a lot to read in the chat here.
Yeah, there are so many questions in the chat.
I'm multitasking
Oh, no.
here. Do you want to pick one out to answer from all of them on the chat line?
There's so many, I can't think of any. Oh wait, there is, okay.
I did see a question about intimate partner violence versus sports injury, and that research, hopefully, I'm working with a couple of groups to move ahead just to try to apply some of the sports, what we've learned from athletes and sports, two people that have been hurt in violence. And again, it's a population that's hard to study and hard to have like come back to the lab every week and for safety reasons. And a lot of that was ramping up, and then COVID added another layer. So there are people ready and waiting to a point where that can happen too. Yeah. So that is a good question. Just because we're talking about athletes doesn't mean that it isn't as equal importance of other mechanisms, how people are hurt by other mechanisms of injury. It's just athletes are usually trapped in one location and, easily swayed into the lab.
Oh, yeah. So the thing is, I really want to clarify that a lot of my research is on athletes, and the athletic concussion population or the athletic mild traumatic brain injury population is very different from others, especially the intimate partner violence group. Just because, when if an athlete gets a concussion, like he wants to go back to the sport. Just having that different mindset of wanting to be better, just to actually be physically better, changes everything. And plus, intimate partner violence, apart from the brain injury, there are a lot of other things that go into there's the stress, there's the fear, there's so many other issues from it that this is not a comparable population. Generally, so a lot of the research always says that concussions from sports-related injuries for adults is like 7 to 10 days, and for adolescents is 14 days. But if you look at the non-sports related populations, in which it's car accidents, those things, more than 30%, it usually takes them like 1 to 3 months to recover. So these are very different populations.
I do always point out when somebody puts up that 14-day slide that was basically tested on white 18 to 23-year-old males at Division I schools with athletic trainers standing next to them, having 18 years of sports behind them. And it's a very specific group. Well, we're at the end of our time, and I do want to be respectful of people who have other places to go at 3. I want to thank you, Dr. Haider, for spending an hour with us. Thank you all for showing up. There'll be links to this on YouTube. I'm now on Clubhouse, if anybody's interested in Clubhouse, and that's another social media. We have links to the paper out on Twitter, LinkedIn. This will be on Facebook. And do you have a 1-minute closing, Dr. Haider, before we head on off?
Not really. I see that there are a lot of questions, so it seems like a lot of people who are curious about my work, which is always nice to hear. No real closing remarks. My research is never ending.
Well, I am very excited to be your friend and to be able to write papers with you, and appreciate all you've brought to my life in this year that I've known you. And again, this is the joy of conferences, when you go to a conference and you can meet up in a hallway and you meet someone like Dr. Haider, and a year later you're interviewing them on your Zoom show. So thank you guys. Please stay safe. Check out social media, read Dr. Haider's papers. Thank you to John Letty and Dr. Willis and the whole lab and everybody at IBIA and NABUS, and check out Clubhouse. See you guys. Thank you.